I'm going to introduce Dr. Stephen Taylor, who's our final speaker. Stephen's talk's going to be split into two with a rep break about 20 minutes in. So Stephen qualified in 1985 and spent 5 years in Bolton becoming interested in ICU and nutrition support. He then worked in Bristol covering ICU and completing a PhD on early feeding in TBI patients and burns, and was also involved in endoscopic NJ placements and energy and nitrogen requirement books. From 2016 onwards at Southmead Hospital, Stephen has been involved in many NJ research projects, including NJs versus prokinetics, attaining adequate protein without overfeeding, advantages of bridle securement, safe versus unsafe ways of interpreting core tract tracers, and development of an Irish tube operator guide, and more on the safety of guided tube placement. So many different projects and research. So I'll hand over to you now. Thank you, Stephen.
Thank you. Can I just check, can you see my slide and hear me?
I can't see your slide at the moment. I can hear you.
Okay, let me try again. You see it yet?
Not quite.
No. Weird. Hold on, I'll unshare and then reshare. Can you see it now?
Yep, it's just coming through. Yep, I can see it now, Stephen.
And now it's on, hold on, it's on full view.
It is.
Great. Okay, just some preliminaries just to begin with. Conflicts of interest. We've had studies sponsored by both CoreTrack and IRIS, but the team speaks its mind without any favour. The images in this talk and others that you've seen, they're all copyrighted to an ebook, and the royalties from that all go to Ukraine relief through a Christian charity called Tear Fund. So please don't share the images or distribute the book, as you shouldn't. And the talk is meant to be as practical as it can be while we're over the internet. So don't just sit there, act when it comes to trying out some of the techniques, either on yourself or on a willing partner or a cabinet minister. I don't mind. Anyway, aims and objectives. The aim is to increase the success rate at which you get into the intestine with your tube, but also to increase the depth if you can. The objectives, I'm going to quickly overview the relevance, which has already been touched on, and the success rates that are expected. I'll briefly talk about the statistical analysis in how we determined whether techniques were successful or not, and then go into detail on the techniques, and then finish with some more of the training that you may require. So just to overview, as has already been mentioned, the deeper you can get into the intestine, the less chance you have of aspiration. So you can see on these figures, once you're in duodenum, part 4 or jejunum, most of the patients don't aspirate, and this was based on finding pepsin in the lung. The other thing is, if you can place a nasointestinal tube, you can then drain the stomach through a separate tube. That also reduces the aspiration risk. And again, it's already been mentioned that you can reduce risk of pneumonia. In terms of success of placement, I'm dividing it, the publications, into where less than 500 placements per centre were published versus expert centres where more than 500 were placed. Now, it's a crude division, but it's the best we can do at the moment. It's already been mentioned, the low use centres get about 50% of their tubes in. This was using CoreTrack. Expert centres often manage over 90%. When it comes to undetected lung placements and the risks, this again is based on CoreTrack because there haven't been enough IRIS placements published yet. You can see that, unfortunately, blind placement appears to be safer than when you're using guided placement if you're a low use centre. On the other hand, the expert centres do brilliantly and don't ever virtually not detect a tube when it's gone into the lung. But if you look at the lower figures on pneumothorax, actually blind placement's much worse even than a low use centre. Now, the reason why there's a disparity where you get undetected misplacements not being found by a low use CoreTrack centre, and yet overall your pneumothorax rates are less, is because undetected misplacements, never events as they're called in the UK, these represent only 3% of the lung complications. 97% of lung complications are when you put the tube in. It happens as you put the tube in. So if you use guided placement, CORTRAC or IRIS, you're less likely to cause a lung trauma and a complication. Expert centres do well with either, though, in preventing them, that is. Immediacy is another aspect you need to look at when you're considering jejunal placement. Waiting for an endoscopist to come and their team, and knowing that if it's the type of endoscope that you put it in and drag the tube in with it and then often pull it out afterwards, you can be waiting days before you've got a successful placement. And if you're waiting, then actually NG feeding straight away gets more feeding than it does from an NI tube, a nasointestinal tube that's delayed. But if you can place the nasointestinal tube within 1 hour, then you can increase the feed versus nasogastric feeding plus prokinetics. And this was dual therapy prokinetics. It wasn't single prokinetic that it beat the NJ placement and feeding. So just talking briefly about the analysis, we looked at 900 patients. All of them, it was first-time placement. The reason we use first-time placement was that if you've got patients where they need repeated placements, you could get bias from that particular patient group. We looked at techniques at 6 different levels, because obviously you use different techniques at each level. For each technique, placements were included in the analysis only if the placement was difficult. Again, if you included placements that weren't difficult, that would create a bias, because if they're not difficult, you don't use a technique. So it almost then seemed as if the technique was the problem. And they were excluded from the analysis, the placement, if an earlier technique had already succeeded, because that would be unfair to include successes in effect another technique had achieved. I won't go into the regression much, other than to say that 5 of the levels were analysed using logistic regression, and it was just a binary analysis. Does a technique make it possible to advance beyond that point or not? Ordinal regression was used for intestinal depth to find out whether the tube actually moved deeper within the intestines. So that was the last stage of placement. And we started the analysis using a single technique, and if that didn't work, went on to analyse combined techniques. Okay, beginning with the nose, there were too few to analyse where it was difficult. But what we do find is a slow advance, angling the tube side to side within the nose, not going upwards into the nose. There is space there, but it's more painful for the patient and it's a narrower space. Lignocaine gel can help the patient if it's very sensitive. That also lubricates the tube. It does sting and it does taste awful, so I'm told. One of the few things I've not tried on myself. You can use nasal decongestant. That reduces swelling and the risk of bleeding, but you've got to be very careful in a hypertensive patient. When the tube reaches about 10 centimetres into the patient, so approximately this kind of length, that is when you could ask an awake patient to hum. The humming drops the soft palate so that the tube can go through into the nasopharynx. And the last technique, and this is rarely having to be used, is that if you know that there's a pathway through the nostril and the nose, but you're finding that the tube just gets lodged on obstructions, you can get a nasal airway, which obviously they're about that long, a size 8 or 9. You slit it along its letter curvature with a pair of scissors all the way, put your tube into the airway, lubricate the airway, and then put the whole thing into the nostril, up to the buffer. That means the tube is now in the pharynx. You hold the tube steady and then you pull the nasal airway back and then just peel it off like a banana skin, leaving the tube in the pharynx, and you've got rid of the airway. The risks that you're running once you reach the pharynx stroke esophagus region is that obviously you could go into the lung. A study we did in 2021 found that with blind placements that ended up going into the lung were 18 centimetres beyond the carina. So in other words, they've gone all the way down the trachea, and then at the point of bifurcation, they've gone another 18 centimetres, which means that quite a few of those tubes have the potential to cause a pneumothorax. And out of 1,800, we found 7 pneumothoraces that almost certainly were caused by the tube, and possibly a couple of pneumonias. CORTRAC, because it detects when there's a deviation, was a median of 12 centimetres, so it didn't go in as far, hopefully not as far as a pneumothorax, causing a pneumothorax, and that is reflected in the data shown previously. Iris was best in this sense because you've got direct vision. You can almost always see that you're in the trachea. Sometimes it's a bit obscured, but you see the carina coming up at the bifurcation and you stop and withdraw before that point. Now, rates of blind placement, as I mentioned, pneumothorax occurs in 0.5% or 1 in 200 patients, which means that if you're passing several thousand in a hospital, which we do, you're going to have perhaps a dozen pneumothoraces in a year. They're often not detected because the tube gets pulled out, detected, pulled out and replaced. Pneumothorax might only be visible on another X-ray a day hence, and they don't link the two. There's a 1 in 400 chance of death. So it is a serious procedure. And as somebody's already said, this is not what you want to see. I don't know if my cursor shows here. It's what I call the baby bird. It's the vocal cords. It looks like a gaping beak, and your tube is heading right for it. Now, if you see that, oh, and I should just explain, this is the epiglottis, which tends to flap at you in a very rude manner. And here, this slit, this dark slit towards the bottom right, is the esophagus. So that looks an impossible target, whereas you look as if you're going to go straight into the trachea. Now, if you see that with direct vision, or you see bifurcation, deviation from the sagittal midline with CORTRAC, or the patient starts coughing, desaturating, ventilator alarms go off, all of those things indicate it's not good news. We draw back towards the nose, so probably 10, 15 centimetres into the patient from the nose, and do something about it. Don't put the patient through this 3 times so that they're traumatized. Now, first exercise in terms of techniques. I hope I'm very visible on screen. If you put your hand, before I go into that, sorry, dry swallowing. I know somebody's mentioned about using fluid. I tend to not favour using fluid for a couple of reasons at least. One, the patient very often chokes on it because they're so anxious and nervous. Sometimes they tilt their head back to swallow. If you're using water, you dilute pH, the stomach acid, and so you won't get a pH result if that's what you're after. So I've tried to get a patient to dry swallow. Now, in terms of techniques, the head tilt, if you put your hand on top of your head now, so let's practice this, run your hand down the back of your skull to the nape of your neck. You feel it curve inwards. So the opposite side to that, the curve inwards, is a curve outwards. So your tube comes in, hits the cervical vertebrae and deflects towards your trachea. If you bring your head forward, so you bring your head now, chin down, put your hand on the top of your head, and I know you've all got more hair than me, but still do it. Move your hand down the back of your neck. It's now a straight line. It's much more likely to head towards the esophagus. Now, you won't be able to do this on patients with cervical vertebrae injuries or trauma or surgery, but you can do it on most patients. The other technique is a jaw thrust. Now, if you could just feel the angles of your jaw here, and if you've ever read, but not admitting it, The Mouse and the Gruffalo, you want to look like the Gruffalo. So either on yourself now or a partner, who may not be your friend afterwards, you firmly but slowly push your jaw forward so that it's like this. Okay? Your lower teeth project beyond your upper teeth. This pulls the tongue and the larynx forward, out of the way, so that there's more room down the back for the tube to go into the esophagus. Finally, you can combine them. So you use your fingers to support the head, and you use your thumbs to push the jaw forward, and you go into this position and then push the jaw forward. I think I say later on, that can take quite a bit of effort when it's over a minute or two. Now, lastly, you might have to use laryngoscopy on somebody who's sedated. Sedation itself can also help because it stops the patient from coughing so much and being anxious. Just a word about anatomy. It's already been mentioned from our very first speaker, but when it comes to guided tube placement, the whole point of it is that you get guidance. You know more or less where you are. And between the operator and a supervisor or trainer, there needs to be communication. It simply doesn't cut it for somebody to say, oh, I think the tip of my tube's stuck in his thingy. That doesn't mean anything. And it also means you can't record data accurately. So you need to know all the different regions of the stomach, the walls of the stomach, the different regions of the small intestine, including the flexures. And if you're using CoreTrack, you need to know the 3 preceding flexures, the pre-GOJ flexure, gastric body flexure, and pyloric flexure, in order to teach and communicate. Moving on now, I hope you've got a tube handy with a guide wire. So first thing I'm going to speak about, so that for later slides when I'm describing techniques, you know what I'm speaking about. Creating a flexible tip. You pull the guide wire back slightly, and it means that the tip now is flexible. By the way, this is not a CoreTrack or Iris tube. It's simply for a demo, and so that I don't get sued for using one rather than another. So you need to create a flexible tip. The other thing is get used to measurements. That is about 10 centimeters. This is about 20. This is now about 30 centimeters. You need to have these by eye in your mind so that, again, teaching and training can be done. When you come to flexures in the small intestine, it's sometimes, yes, useful that your dominant hand is, your non-dominant. In this case, I'm a left-hander, so I'm holding the lure here in my right hand, and my left hand, my dominant, is holding the wire. Obviously, most people do it the other way around. You may maneuver that way, but sometimes at a very crucial point, you want to be able to use your dominant hand to do the directing of the tube whilst you move the wire in and out. So you can have 1 minute a flexible tip like now, next minute the wire's fully in to check whether the tube has gone around the flexure, and you feel it by the less resistance once the wire is around the flexure. Sometimes you need to do it simultaneously, and you only have 2 hands. Finally, when it comes to wires, you may have your main guide wire in, and you need to stiffen the gastric portion of the tube. And so you insert 1, sometimes more than 1 tube. We've gone up to 3 extra wires, so 4 in total, tube to stiffen the gastric portion of the tube. So you're using your main wire to direct the tip, and it might go in and out to create a flexible tip. And then you've got a stiffener wire, or more than 1, stiffening the portion of tube still only within the stomach. And as you gradually insert more tube into the intestine, you're gradually moving the stiffener wire out so that the tip of the stiffener stays within the stomach. Okay.